Please listen carefully.
Hello and welcome to GasGasGas, the podcast that covers the FRCA primary exam. We're going to fit into your day and give you as much of your life back as you could possibly imagine. I'm here to make your studying easier. Listen to us on your commute, in the gym, in the shower, or when you're ironing your scrubs. Expect facts, concepts, model answers and the odd tangent. Check out the show notes for all the detail and remember to follow the show so that you never miss an episode. Let's get on with it. So hello Tom, welcome to your Physiology Viva. What factors govern the oxygen content of the alveolus?
So, the oxygen content of the alveolus can be thought of in relation to the gas enchained into the alveolus and some changes that occur on its way there. So, the atmospheric concentration and partial pressure of gas is initially important. So, in an environment with 100% oxygen, then you'll have a much higher percentage reaching the alveolus. In a typical situation with 0.21 fraction of inspired O2, we have an initial reduction in the concentration of oxygen as air is warmed and humidified in the upper airways. As the gas descends from the nasal passages and the oropharynx, it mixes with exhaled air from the previous respiratory cycle sitting in the upper airways. This then further reduces the concentration of oxygen in that mixed gas, which now contains CO2 at a much higher concentration. Moving further down towards the alveolus, humidification also increases further, and we have that final concentration in the alveolus that's dictated by those things. So atmospheric concentration of oxygen, humidification within the airways, and mixture with expired gases.
Lovely. And is there an equation that unifies all these things?
Yeah, the alveolar gas equation unifies all of these things. So the alveolar gas equation will allow you to calculate oxygen concentration within the alveolus by relating it to respiratory quotient and the end-tidal CO2 content and arterial CO2 content. The alveolar gas equation will allow you to calculate alveolar concentration of oxygen by relating the fraction of inspired oxygen to the...
Hey there Tom, you need to be much quicker at getting the equations out. I don't want to hear how they all relate to one another because the equation will tell me that. If you start prevaricating, then the examiner's going to smell a rat. So you've just got to get the equation out into the open so that the examiner thinks... Can be like, right, okay, now we can move on, yeah, I know you know it.
Oh, okay, I thought I was describing the wrong equation. Anyway.
You got the concept there, but you lost time, yeah.
Need to be quicker. Oh yeah, no, I couldn't remember. I was trying to remember the concept while I gave myself a chance to remember the constituents.
So PaO2 equals the fraction of inspired oxygen times by the amount of humidified air as a partial pressure knocked off your atmospheric pressure minus the PaCO2, so the arterial CO2 content divided by the respiratory quotient.
It's one of those that's definitely easier to write down.
100%, yeah. And how does this alveolar oxygen content compare to mitochondrial oxygen content?
Alveolar oxygen content is significantly higher than mitochondrial oxygen content because gas needs to diffuse, first of all, across the alveolus, which in normal physiology it will equilibrate, and PaCO2 is a very close approximation of... PaO2 is a very close approximation of alveolar oxygen, but beyond that point, in order to reach the mitochondria, oxygen has to diffuse across endothelial walls via interstitial fluid into the intracellular fluid and then to the mitochondria itself. So whilst it's carried very efficiently bound to hemoglobin in blood, the amount of dissolved oxygen that can reach the mitochondria is significantly lower than the concentration found in blood.
Could you hazard a number on that?
I believe it's 1.4 kilopascals at the mitochondrium.
Okay.
Sorry.
Yeah.
I was going to say compared to concentration in air, which is about 21 kilopascals.
So why is there a difference in P big A alveolar O2 and P little a O2 of arterial oxygen content?
In normal physiology, there is a difference between those two due to physiological shunting via veins within the lung itself and via the thespian veins draining directly into the left atrium from the heart. So those small amounts of blood are not oxygenated before they reach the systemic circulation.
Okay, could you classify these different types of shunt in a bit more detail for me?
Shunt is essentially a concept of a proportion of blood that reaches the systemic circulation without being oxygenated in the lungs. So we've already mentioned physiological shunting, which is in normal physiology. We have various types of pathological shunts. So we can have right to left shunt in the heart, such as with atrial septal defects or ventricular septal defects, that lead blood to pass without going through the pulmonary vascular bed and therefore not being oxygenated. We can have shunt because large areas of the lung aren't perfused, such as in pulmonary embolus, so an obstructive type of shunting. And we can have areas of the lung that are not at all ventilated, and therefore blood can be shunted from left to right side of the circulation without being oxygenated via that process, such as in pneumonia.
Okay. And are there any pulmonary mechanisms that could counter this poorly ventilated alveolus that you mentioned?
Yes, so we've evolved a mechanism for making oxygen absorption more efficient in situations where areas of the lung are not oxygenated, namely hypoxic pulmonary vasoconstriction. So there is a direct effect of partial pressure of oxygen within the interstitial fluid of the lungs on the small vessels of the lungs, such that the lower the partial pressure of oxygen, the higher the tone in smooth muscle, i.e. higher levels of vasoconstriction. This, in effect, reduces the flow to those areas of lungs with low partial pressures of oxygen, and the blood instead is shunted elsewhere into the vascular bed of the lungs, normally to better ventilated areas of the lungs where oxygen uptake is more efficient. In some pathophysiological states, though, there can be problems with this mechanism as well, and if the entire lung is suffering from low partial pressure of oxygen, this can actually be a harmful mechanism rather than a helpful.
Just out of curiosity, you mentioned harmful. How so?
So in lung disease that leads to globally reduced partial pressure of oxygen in the interstitial tissues, you get hypoxic pulmonary vasoconstriction in the entire vascular bed, leading to pulmonary hypertension. This can also lead to right heart failure. So classic example would be cor pulmonale in patients with chronic obstructive pulmonary disease.
Excellent. So you mentioned some pathological things that are somewhat incompatible with hypoxic pulmonary vasoconstriction. Are there any pharmacological agents you know of that alter these mechanisms?
Yes, inhaled nitric oxide can be used as a pulmonary vasodilator, and this can be used in some critically unwell patients with right heart failure and pulmonary hypertension. There are other pharmacological agents that can be used in chronic pulmonary hypertension orally in order to vasodilate the pulmonary vascular bed, usually prescribed under the direction of a cardiologist, which includes, I can't recall the names of the oral agents actually. We also see dilatation of the pulmonary vascular bed when we administer volatile agents in anaesthesia, which does cause some extent of VQ mismatch even in healthy patients, which can go to explain the required high fraction of inspired oxygen needed to maintain normal saturations even in healthy patients.
Lovely. So HPPV is clearly a local oxygen sensing apparatus for managing oxygenation on a tissue level. What other sensing apparatus are present in the human for oxygen and CO2 levels in the plasma?
So I'll begin with oxygen sensing within the plasma. So partial pressure of oxygen in blood is sensed by specialised cells within the carotid bodies, and this can via links to the central nervous system, can directly modulate respiratory drive. In terms of, just repeat the wording of the question again, 'cause you wanted to know about CO2, but did you say specifically?
Just oxygen and CO2 sensing apparatus for the plasma in the body.
For the plasma in the body. So the reason I asked again was just to be clear about the plasma part. So for sensing CO2 content in plasma, there's no direct mechanism. However, H plus ion concentration is proportional to carbon dioxide partial pressure within plasma, because carbon dioxide readily dissociates into carbonic acid, and so it creates water and H plus ions. So carbon dioxide itself can freely cross the blood-brain barrier and reach the interstitium of the brain tissues. At that point, when carbonic acid is formed and H plus ions alongside it, those H plus ions are sensed centrally and directly modulate respiratory drive via the respiratory centres and the medulla oblongata.
Lovely. Trying to keep things on topic. We have a carotid body and we have a carotid sinus. What sensing mechanisms are present in the carotid sinus?
The carotid sinus contains baroreceptors that respond directly to blood pressure and create increasing neuronal outflow in response to lower blood pressure.
And
in the
sorry. Just to jump in there. And are you aware of any sort of manoeuvres we can use to manipulate this mechanism to our benefit as physicians?
So by conducting carotid body massage, we can induce increased parasympathetic outflow in order to try and lower heart rate. This can be particularly useful in supraventricular tachycardias as an initial technique.
Yes, and if your carotid sinus massage might fail in a patient with a supraventricular tachycardia, what other manoeuvre might you consider?
In terms of other vagal manoeuvres, we can get them to perform a Valsalva Manoeuvre, which are different techniques for doing. Trying to blow the plunger out of a syringe is quite a common one and can be quite effective.
Can you talk me through the phases of the Valsalva Manoeuvre?
I can. So the Valsalva Manoeuvre is conducted by closing the larynx and by contracting the muscles of the chest wall in order to increase intrathoracic pressure against the closed glottis. The initial phase of Valsalva, phase 1, increases venous return by compressing venous structures within the thorax. This leads to increased preload, increased stroke volume, and decreased heart rate initially. As this bolus really of pooled venous blood exits the heart, we then have decreased venous return due to increased intrathoracic pressure, which leads to a subsequent tachycardia, a slight drop in blood pressure. In the third stage, we have opening of the glottis in this third stage, which leads to, again, increased venous return to the heart. The tachycardia itself resolves and the blood pressure increases again. And I can't recall the fourth stage at this point.
Okay. Well, the fourth stage is the money shot. So the third stage, you stop the Valsalva, so your pulmonary vascular resistance goes back down, which means that the blood that was squeaking through the lungs just fills the lungs again. So your venous return doesn't really get better or worse, and you drop your blood pressure at this point.
Because the pulmonary vascular bed is filling.
Yeah. And then the fourth phase is
return to normality.
Except for this reflex blood pressure drive that's occurred as your body detects that it needs to increase SVR to drive blood back to your heart.
Yeah, so those catecholamines are still working, so you still remain slightly hypertensive compared to before.
And then you drop your heart rate because your cardiac output's back to normal, and your brain's like, whoa.
Yeah, okay. So something that did confuse me, we glossed over it in the middle of that. The carotid massage.
I was actually going for a Valsalva manoeuvre, but you just told me about carotid sinus massage, so I thought, okay.
Just because we were talking about carotid bodies, it was the first thing that came into my head. So when you massage the carotid body, it's nothing to do with the baroreceptors, is it?
I think what you're doing is you're increasing the pressure in the baroreceptor, and it's going, well, my pressure's fine, high, but my cardiac output's normal, so I'm going to drop heart rate. That's my understanding.
Oh yeah, so it's to do with baroreceptors because you directly. But I was thinking before, so decreased blood pressure leads to increased outflow. So yeah, you're reducing your sympathetic outflow. It's because I was having to flip things in my head. It's like a double negative, isn't it?
It is confusing, that's why they ask.
That's what they ask you. Okay. Do you want to run that again?
Yeah. So, Tom, you've mentioned the carotid body there. You also have a carotid sinus that is involved in detecting blood pressure changes. What manoeuvres can you think of that we can use to influence this receptor to our advantage?
We have carotid belly massage or Valsalva manoeuvres can both be used to manipulate this mechanism.
Yeah, so thinking about the Valsalva manoeuvre, could you talk me through that, please?
Yeah, so the Valsalva manoeuvre is performed by contracting the muscles of the chest wall against the closed glottis and is usually described in 4 phases. So phase 1 sees an increase in intrathoracic pressure, which leads to increased return of venous blood to the right side of the heart through compression of venous structures in the thorax. This leads to increased preload, increased cardiac output, and an increase in blood pressure, which itself results in a reflex bradycardia. In phase 2, as that essentially bolus of blood from the venous system runs out, we have decreased venous return into the right side of the heart. We have increased pulmonary arterial pressures from the increased intrathoracic pressure, and so we get a decrease in blood pressure and a reflex increase in heart rate in order to compensate for that. In the third stage, we have opening of the glottis, which leads to a drop in intrathoracic pressure. This allows free flow of blood from the right side of the heart into the pulmonary vascular bed. We get a initial drop in blood pressure at this stage and an increase in heart rate. Oh, I said it the wrong way around. There's too many moving parts here, James.
Because that's the crux. That's the whole thing is the heart rate goes down because the blood pressure has overshot. And the fourth
stage of the Valsalva manoeuvre shows an overshoot in blood pressure resulting in a relative bradycardia compared to before the manoeuvre was begun.
All that waffle is just so you can get there and be like, and there's an overshoot in blood pressure and a reflex bradycardia. Excellent. And how would this bear out in a patient with significant autonomic neuropathy?
So patients with significant autonomic neuropathy, such as spinal injury patients or diabetic patients in some cases, will show that an inability to respond to the changes in blood pressure as described in the Valsalva manoeuvre. So their blood pressure will drop more significantly initially, and they won't then overshoot and develop hypertension or bradycardia at the end.
Excellent. Lovely. And that is the end of your Physiology Viva.
Thank goodness for that.
How do you feel about all those questions? We did the Alveolar Gas Equation, and then we explored shunting, hypoxic pulmonary vasoconstriction, oxygen sensing, CO2 sensing, and then Valsalva Manoeuvre.
Okay, I think sums it up. Okay, but I think equations, there are a few of them that I think I need to be a bit quicker having on the tip of my tongue, or I think it does actually help to write these things down. I think it's a good technique in the exam because it can be quickly inspected and recognised to be correct. It takes a very long time to say the alveolar gas equation out loud, and it's quite easy to say one part of it incorrectly, and a sharp examiner will pull you up.
Yeah, and it means that you can spend less time demonstrating that you know what the answer is.
The other areas, I think it can be difficult to know how much depth to go into sometimes. Again, I think we've talked about this before, but general exam technique, I'm trying to begin with broad strokes and allow the examiner to focus me. It can be easy to lean towards things that you know rather than answering the question sometimes.
Yes, I noticed that you mentioned telling me about central nervous system CO2 sensing when I just asked you about the plasma.
Yeah, so I think that's a knowledge gap. So I I asked you to repeat the question, didn't I? And when you said in plasma, I was thinking that it was all centrally sensed. But do the carotid bodies contain pH-sensitive cells?
I do believe they do.
Yeah,
But
I wondered if they did, but I wasn't confident, so I didn't commit myself to saying it. So that's a learning point for me then. So do you have any more detail about CO2 sensing in the carotid bodies? Is it direct sensing of CO2 rather than H+ ions? I think that rings a bell.
yeah, it doesn't do any of the clever stuff that you were talking about because of the blood-brain barrier.
It's the partial pressure CO2, and an increase there increases respiratory drive.
Yeah, your body does PO2 and PCO2. The sinus does pressure, doesn't it? And then there's also stuff in the aortic body.
Yeah, so you asked in the question, I think, about aortic body. Oh, no, you didn't ask about that. You asked about carotid sinus versus the carotid bodies. And my memory started failing me there again as well. So carotid body compared to the carotid sinus. In the carotid sinus, you have baroreceptors. And in the carotid body, that's where you have your chemoreceptors for oxygen and PCO2.
I imagine in the exam, I wasn't going to ask you to do it over audio. They might want you to describe the Shunt equation.
Yeah, so as soon as you start talking about shunts, I started scrambling my head for the Shunt equation, and if I'd have been confident, I probably would have stated it.
It's a big one.
Yeah, that's the thing. Especially without writing it down, I think it would have been a mess.
Yeah.
It's going to be in the show notes, no doubt, James.
It will be in the show notes. I do have a clinical question, depending on how much energy you've got. And if you want a clinical question or not.
I'm fine. I think I'm doing a bit better than you at this point.
Yeah, it's been a long day.
Hard work. And having to listen to me bang on about primary stuff.
Yeah, and having to pay attention and be like, shit, I should have checked this. It's actually quite hard to write Viva questions because, like, you end up writing an essay, like, as an answer that you're looking for. It's like, even when I've used books and stuff, you can't just have a load of pages up and it's not easy. Anyway, I'm complaining. Are you ready for your clinical Viva, Tom?
Ready as I'll ever be.
You're on call and you've been asked to see a patient with bowel obstruction and a perforation.
Naturally, everyone, time is not linear in Gasland, and therefore, if you do want to hear about Tom's delightful excitement into his oncolaparotomy clinical station, feel free to listen to the last episode. Anyway, thanks for listening. See you next time. For more VivaCast fun, it's pharmacology time, and Tom's doing Adrenoceptors, the lucky sausage. Thanks for listening to that episode, guys. If you found it useful or awful, please like and subscribe and rate the show. Definitely go check out those show notes on GasGasGas.uk. We all know that this is a bucket of content. I want you to take some time for yourself and don't overcook it. Don't freak out. Keep studying.